So the last
I'm not going to
talk
spend a
of
lot
the
of time on
day
anatomy, but I just did want to show
given
these
by
two quick.
Dr. Theresa Hadlock. She is the Professor Larry Gooseberg Endowed Professor for Otology and Laryngology at Harvard Medical School and the Director of the Facial Nerve Center at Massachusetts Eye and Ear Infirmary. She's a graduate of the joint program of Harvard Medical School and MIT. And she is an accomplished clinician scientist. She has a research and clinical interest in facial nerve paralysis and surgical approaches to that, which she is going to talk in more detail to us about today. Please remember, if you have any questions, to submit those either through the Hoover app or talk to Kate directly so we can get those answered for you. Thank you.
So I'm not going to spend a lot of time on anatomy, but I just did want to show these two quick pieces of art that indicate the anatomy of the facial nerve. On the left, you can sort of see that the facial nerve comes out of the brainstem and then it travels very circuitously all the way through the solid temporal bone and comes out of the skull at the stylomastoid foramen. Now, in this piece of art, it kind of has different colors for the different segments, and that's really so that clinicians can refer to the area that they think might manifest disease or tumor. Now, on the right, you can see that when the facial nerve comes out of the skull, it wraps around and multiply branches as it works its way toward the muscles of facial expression. And this piece of art demonstrates really the 12 important muscles of facial expression. At the top, we've got the frontalis that raises the eyebrows. Then we've got the oculi that closes the eyes. Then you've got the 3 lip elevators. Levator labii is the very vertical muscle, and then zygomaticus major and minor that create that upward-outward smile. Then you've got some lip depressors like the DLI that really brings the lower lip away when we say E and things like that. There's also a muscle called the depressor anguli oris, which is more of a really significant frown muscle, not one that we really use too much. And then, of course, this big platysma muscle in the neck, and we'll talk more about how that muscle can actually hurt us in different kinds of facial palsy conditions. So when we think about facial paralysis, I just made a list of like all the things that can happen when somebody suffers with facial paralysis. You've got ocular issues or issues around the eye, and those can involve the eyebrow sitting too low and having like a kind of a cutoff of your visual field. You can not protect your cornea well because you're not closing the eyelids well. So if you lose blink, then you don't have that windshield wiper that cleans the cornea all the time. And you can suffer from ocular dryness if you don't have enough tear production. Around the mouth, you can develop what we call oral incompetence or drooling, or when food or liquids are lost out of the corner. People can sometimes develop speech and articulation problems, especially with sounds like P, B, the plosives, where we need to really bring our lips together tightly. Sometimes inside the mouth, we have poor manipulation of food, so we can't kind of push food into the line of our teeth and it gets pocketed in the cheek. But aside from just the functional issues, there are aesthetic issues, right? In other words, it can look unsightly, or it can look or feel disfigured. And then finally, in facial paralysis, there really is a communication deficit where people cannot express themselves non-verbally and tell the story of their emotions on their face. And so as a facial reanimation physician, I like to think about all of these issues as really equally important: the functional problems, the aesthetic problems, and the communication problems. So let's talk about what can happen to the facial nerve in NF2. Well, either patients with NF2 can have completely normal facial function, like this photograph demonstrates, or they can have unilateral flaccidity on one side, meaning real weakness. They can have weakness on both sides, bilateral flaccidity, or they can have what we call non-flaccid facial paralysis, which is more a sequela of when the face gets weak and then recovers, like let's say after skull base surgery or after some trauma from resection of vestibular schwannoma. That's called non-flaccid facial palsy, or NFFP, and that results not in that flaccid loose face, but in a face that's too tight. And they can also have that could happen to patients on one or both sides. And occasionally we might see a patient who has flaccidity or the looseness on one side and the tightness on the other. So let me show you a few examples of that. So here's an example of somebody with unilateral flaccid paralysis on her left. So at rest, she's got sort of where the corner of the mouth comes down a little bit, the nose is a little bit collapsed, and the eye is a little wider open. And then when she smiles, there's no perceptible movement here. If we look at the unilateral non-flaccid, or more that frozen face, I like to think of it, this condition is on the right side. So at rest, she looks pretty balanced, but in fact, the right eye is a little more narrow compared with the left eye. And then when she goes to smile, the frowning muscle is activating, the neck muscle is activating, and the eye is tight. So that's really the difference. That's kind of two flavors of facial paralysis. And we want to think about what flavor we fall into, because management differs quite a bit based upon that. This is an example of bilateral elements of flaccidity. So he has some periocular issues, but you can see that there's no movement, there's no tightness, and there's really only just a little bit of discernible smile on this side, but but in general, no really meaningful smile on either side. This patient manifests flaccidity on one side, on the right, and tightness or non-flaccid facial paralysis on the left. So when she goes to smile, the right corner doesn't move at all, and the left corner moves in kind of a very tight, sort of lateralized way. So when we try to make a plan for facial paralysis associated with NF2, we first have to think about what bucket that face is in and how that face is going to evolve over time. So the other thing to really keep in mind in NF2 is that the facial palsy situation can evolve. And this patient with NF2 really tells that story nicely. So when I first met her, here she is at rest, and with smiling, she had a little bit of a meaningful smile on the right, but nothing on her left. So we did a muscle transplant on the left side and got this nice smile on the left. But her right side then progressed to flaccid facial paralysis on that side. And then we went doing a muscle transplant on the right for more of a balanced smile over time. So I think it's important when you're trying to think about a plan, you want to think kind of longitudinally, and most importantly, you want to respond to the changes that evolve in that face over time. This condition is not like one-stop shopping. Now, before we talk about all the different things that we can do in NF2, in facial paralysis in NF2, I think it's important to think about the special considerations that are brought in by this condition. Number one is that immunologics and other chemotherapeutics that are really useful against tumor growth and tumor explosion can also affect wound healing. So we have to be very sensitive about those issues. For example, patients really require an Avastin holiday even if they're having any kind of elective facial manipulation. Patients are often deaf, and so we have to think very sensitively about communication issues with these patients and so forth. And when patients have had an ABI, we can't use monopolar cautery, which is something that we commonly use in the face. And so we have to find different ways to kind of control bleeding and bruising. The other thing about NF2 is that, again, it can affect both sides. We have to be ready for that. So, for example, we don't do a lot of reconstructing by using opposite side facial nerve branches because those are kind of also at risk. And I think the lifetime risk of a problem on the opposite side is 24% or so if I just look at my own series over time. The other thing, too, with NF2 is that I feel like a lot of clinical decisions are made based on quality of life, and people don't want to be having surgery, every 20 minutes. And so sometimes there are tumors that are really impinging on gait and the ability to ambulate and move around, or they cause pain or something else that's kind of higher priority than bringing back facial expression. And so it's important to prioritize surgery for tumors that might be impinging upon vital structures or the spine or something. Okay, I just alluded to this a second ago, but just when I look back, probably 5 or 10 years ago, I looked back at our own NF2 experience, and in 100 randomly pulled cases, I just saw there was a slight preponderance for right-sided facial paralysis versus left. I don't know that this really has statistical significance, but almost 25% of patients did have some kind of bilateral involvement. And so I think that really lends credence to the idea that we don't want to use a lot the contralateral facial nerve branches because we don't want both sides to be dependent on the one side that's functioning at a single moment in time if that side is going to ultimately potentially be at risk as well. Okay, so when somebody comes into the facial nerve center at Mass Eye and Ear, we really need to evaluate them. We've got to assess them and figure out where they are at that snapshot in time. And then we might develop or we might implement a plan. And then we've got to circle back and get another snapshot of where they are. So what kind of protocol do we run them through? Well, a former fellow of mine named Joe Dusseldorp kind of coined this term, the palsy protocol. And I really like it because it's sort of, each one of these letters stands for something very important about patient assessment. The P stands for patient-reported outcomes measures, meaning the condition from the patient's perspective. A stands for automated and clinician-graded function. That means what does the computer see and what does the doctor see? L stands for layperson impressions. What that means is, how does a particular patient affected with facial palsy look to a naive observer? Are they disfigured? Are they not disfigured? Can they blend into normal? And S stands for spontaneity, because we have a lot of ways of bringing back the smile, but only some of them are truly spontaneous, meaning involuntary, meaning you're laughing alone at a funny movie and your smile would move. So spontaneity is something important to measure. The Y just kind of completes the word. So the first thing that happens when somebody comes into the facial nerve center is, of course, we take a history and we do a physical exam. We figure out whether there are elements of flaccidity, hypertonicity, or both. And then we take this panel of photographs. And on the top, you can see this woman has flaccid facial paralysis. Here she is at rest, brows elevated, eyes gently closed, eyes tightly closed, small smile, big smile, ooh and ee. In contrast, this woman on the bottom has non-flaccid facial paralysis. She's making the same expressions, but as you can see, when she's making those expressions, she has a totally different set of issues. So I like to look at this big smile one. Here, the eye is too wide, the corner of the mouth is too low, and the nose is rolled over toward the healthy side, and there's no nasolabial fold. There's no crease here. Same expression in the non-flaccid face. The eye is too narrow. The crease here is too prominent. The corner of the mouth is being actively pulled down, and there's all kinds of tension in the neck. So as we move into kind of talking about treatment plans, you're going to understand why it's important to figure out which bucket the exam fits into so that you can make the appropriate plan. Okay, we talked about patient-reported outcomes. We tend to use a tool that was developed here in the late 1990s by an outcomes expert named Richard Glicklick. It's a very simple questionnaire that was rigorously validated, and it has been translated into multiple languages, and it's really a nice kind of worldwide tool where we assess a snapshot of where the patient is, and then we might do an intervention and then reassess from the patient perspective, and it helps us know whether patients actually feel that they are improving. There are a number of other instruments, and I don't feel that strongly about which instrument is used, but I do feel pretty strongly that some instruments should be used on patients who are undergoing manipulation for their facial paralysis. Automated and clinician-derived outcomes. We developed here what we call the e-face, or sort of the electronic facial assessment tool, but we also have kind of some next generation tools called Emotrix and Auto eFace that I'll show you at the very end. But you also might have heard of the Sunnybrook scale, the House-Brackman scale. These are all just languages that we use as clinicians to try and compare notes. The thing I love about the eFace is that it's a digital platform. It's kind of it's available on smartphones, tablets, on a desktop application, or on paper, and it allows you to look at every aspect of the face. So at rest, these static parameters, we look at the brow position, how wide open the eye is, the crease here, the position of the mouth, and so forth. So it's a very good systematic way of looking at the face. Okay, layperson proxy. It's really hard to get a sense of what a layperson would think about a specific face, but a company did develop an app called AFDEX Research, where you can actually put in a video of somebody trying to smile and and it will report what the likelihood is that a naive observer would read joy on that face. It was designed so that people developing commercials and things like that would get a sense of how impactful their commercial was, how often their commercial evoked joy, and so forth. But we've sort of morphed it into this tool for facial palsy. And so this emotionality quotient, again, worked on largely by Joe Dusseldorp, kind of gives a score of how often joy is being predicted on the face versus contempt versus disgust. So what you can see is in a normal patient, who smiles, the computer on this particular face reads that 100% of people would read that as a smile. But in flaccid facial paralysis, a person smiles, and 99% of the time, a naive observer would read contempt. And in the non-flaccid facial paralysis, observers will read both joy and contempt in the same expression. So this layperson proxy is a really good way of getting a barometer on what others might think after facial palsy treatment. And spontaneity, as I mentioned, such an elusive but important feature of facial reanimation. An app has been developed, again, by the Australian group that's called the Smile Check. And basically the app allows somebody who's had facial reanimation to look at their phone, watch a funny video, and it records how often there's movement on the affected side when the healthy side is triggered. So for people with unilateral facial paralysis who've had facial reanimation on the other side, the Smile Check app kind of reports how often there is appropriate smiling activity. So it's sort of a digital attempt at telling us when there's a spontaneity in the smile. So when a patient comes in, we do the history, the physical, we take the photographs, we do a video clip, we do some of that spontaneity assessment, and then we use the Mass-Eye clinical approach, which is to say, after that global and zonal assessment, we develop a comprehensive plan, which I'm going to spend the rest of the talk talking about. We execute the plan. We give the patient that same assessment battery that I just talked about. Then we say, where are we? What are the residual issues? And from there, we refine, we add interventions, we do things that address the ongoing deficits. And once again, we do our global and zonal assessment, and it goes on and on like a flywheel until a patient really arrives at a point where they're satisfied with their overall picture. So what are those comprehensive plans? What are the things that we can do? Well, we think a lot about the plan for an NF2 patient or any facial palsy patient in terms of multimodality management. In other words, it's not like one thing that can be done. We do a lot of medical therapy that involves the right medications at the right time and Botox injections into the face in very specific locations to help the situation. We take extreme advantage of physical therapy, and of course, I spend most of my professional effort on surgical therapy. So spend some time talking about the surgical therapy and what can be done for each zone. So we talked before about how we look at the face very systematically from the top down. And in the upper face, we're talking about the eyebrow, the upper lid, and the lower lid. In the mid face, we're talking about the nasal valve, or sort of the nostril. We're talking about the nasolabial fold, the resting position of the oral commissure, and even the resting position of the philtrum. When we talk about the lower face, we're talking about the lower lip, the chin, and the neck. I forgot to mention in the midface, the most important thing, how much that oral commissure moves for. So let's start at the top and we'll work our way down. At the top, we think first about brow position. Sometimes the brow is too elevated. We can give a little Botox above it, or we can Botox below the healthy eyebrow and move it up a little bit. That's called the chemical brow lift. Surgically, if the brow sits too low, like in this gentleman, we can make an incision way up in the scalp and we can just pull up the brow, kind of through a mechanism that's depicted in this piece of art here. We make a little incision, we dissect this tissue down, we put a little dissolving device into the bone here. It's got some prongs on it, so we lift that soft tissue up, stick it onto the prongs, and we reposition that brow into a nice position, and you can see here he is with good brow balance. Here's another example of like a lot of brow ptosis, and this is not really good to leave because the skin cells over here are basically going to fall right onto the eyeball, and if somebody can't blink well, they don't have the ability to clean those desquamating skin cells. So you really do want to pick up that eyebrow, and here you can see she is postoperatively with the eyebrow in a better position. All of a sudden she's got a nice upper eyelid that you can see the whole way across. Same with this gentleman down here, so much heaviness with the skin falling right into the eye, and here we've picked the eyebrow up. In fact, in this guy it's almost like a little too high, but that's much better in terms of ocular health. Moving down to the upper eyelid, we do tend to put in a lot of these thin profile platinum eyelid weights. This is normally a very simple office-based procedure. It takes about 15 minutes. In kids older than about 10 years old, I just do this in the office, and occasionally even on younger kids, and certainly adults. We make a little nick in the supratarsal crease, that is to say the crease in your upper eyelid, so it doesn't make any visible scar. And we put this very thin profile piece of platinum there that helps gravity help close the eye. We don't really favor using the gold weights because gold has a certain amount of reactivity, and the gold can kind of create a capsule around it where it almost looks a little too puffy. The platinum is more dense, so the implant itself is thinner, and it also doesn't have that issue with the reactivity. So here's a lady who's closing her eyes gently without the weight, and here she is where she's closing her eyes gently with that weight, and you can see what a big difference it makes. And so this is something that I have a very low threshold to do, because if something went wrong with it, or you didn't like the way that it looked, or it was a little too heavy, or this or that, it would only take 5 minutes to take it out. So it's sort of like one of these reversible situations that I think there's like a big benefit for very little price. Sometimes the problem is in the lower lid where it's displaced way down here, and you can see here this gentleman is with eyes open and eyes closed, and the real problem is the dominant issue down here. And in these cases we need to make a little nick at the side of the eye and pick up the whole lower lid complex and kind of just sew it into the proper position. And again, this is all done just in the office. Very occasionally, patients need to undergo what we call a tarsorrhaphy, which I don't love and I'm not a huge fan of. We really only do it when the eye is at extreme risk or has some kind of infection where the only way that it can heal is if we sew the lids together. This one is called a central tarsorrhaphy, and here's a more lateral tarsorrhaphy. And again, these are not aesthetic at all, and so we try to stay away from these except for when there's no sensation on the cornea, and even when that's the case, with the advent of things like the Prose lens and other bandage contact lenses, I think the tarsorrhaphy is used less and less and less. Okay, now moving down past the eyes down into the middle face. As I mentioned before, the nasal valve can collapse. The nose can sort of roll in, like you can see in this top photograph. And really, if you go like this, and the airway is much better, then you have what we call nasal valve collapse, and that can be rectified by surgically opening that area. There are a number of different surgical approaches to it, but one that we use very commonly is by taking a little piece of fascia out of the leg and then basically stringing it through a small incision here and an incision like a facelift. We just tunnel it through that area and we sew that piece of fascia to the side of the nose. We just pull, and it really opens up that airway nicely, and a number of clinicians here have established the benefit of that to the nasal airway. Okay, now let's talk about smile reanimation. There are 4 very nice approaches to smile reanimation. Each of them is appropriate for a little bit of a different clinical scenario, so this is not one-size-fits-all stuff. But static slings, meaning slings that don't move but just reposition structures, are excellent in patients who can't tolerate more complicated surgery or are not interested in actually getting movement, or are poor surgical candidates or poor healers or that kind of a thing. Regional muscle transfer, those are things like temporalis muscle and masseter muscle operations, are reasonable approaches, but they don't usually yield the same kind of excursion movement as free muscle. So these days, most people undergo free muscle transfer, even though there still is some role for regional muscle transfer. The other approach to smile reanimation is what we call reinnervation, or nerve-to-nerve transfer, where we flip an alternative motor nerve into the distal facial nerve, and if we control that motor nerve, we get movements. So let's talk about these different approaches. Here's a static sling. This guy has a poor prognosis, not a good surgical candidate, just gets some fascia lata out of the thigh, several ribbons into the face, and you can see he goes from really feeling uncomfortable at the dinner table to being somebody who can sit with his grandkids and look relatively normal. So that operation is only about a 90-minute operation, very worthwhile in people, especially people who have other medical issues for which you just don't want to put them at risk with a more lengthy operation. These are another few examples of how you just don't want to leave somebody flaccid like this, even if they do have multiple comorbidities, and it's still really worthwhile to pick up the face because the degree to which you make them look more normal is pretty impactful on quality of life. Again, this lady shows it here too. She's got this flaccidity, and just after a simple 90-minute thing, we're able to kind of pick up the lower eyelid, make the nasolabial fold, pick up the corner of the mouth, stabilize her philtrum, and all kinds of other things. But free muscle transfer is what we spend most of our time doing. It's really cool because when you take up muscle from somewhere else in the body and bring it into the face, you can drive it by a chewing nerve, or you can drive it by a cross-face nerve graft. And when you use the cross-face nerve graft, you have that potential for a totally spontaneous smile. Now, in NF2, we don't take that approach too often if we really believe that the other side is imperiled, let's say by an enlarging contralateral vestibular schwannoma or something like that. The muscles that have been used to transplant into the face include the gracilis muscle, which is in the inner thigh, but also one of the chest wall muscles called the pec minor, and a back muscle called the latissimus dorsi. So each of these has pros and cons that I think are a little bit beyond the scope of this, but essentially we like to focus on the gracilis muscle because it's easy to harvest at the same time as working on the face. If we do it, if we are going to drive it by a cross-face nerve graft, in the first step, we make a little nick in the ankle. We pass a camera into that nick, and you can see this is a view from the camera where the sural nerve, the donor nerve, is lying right here at 6 o'clock, a big, healthy white nerve, and we can run it and we can cut it up at the top of that tunnel, and then we can extract a nerve really this long just through that one little tiny nick there. And this, I don't think the audio, I don't know how to shut off the audio, but basically when we open the donor side, we stimulate the different branches and we find a very nice branch that makes a smile, just like that branch that I'm touching the nerve stimulator, and we're going to actually cut that branch and sew it to the sural nerve and bring the sural nerve across the face in preparation for the second step. So let me show you some examples of the free gracilis transfer. These are ones that are not driven by the cross-face nerve graft, but I specifically picked NF2 patients for whom we most often just take one of the chewing nerves and we plug it into the muscles, the gracilis muscles nerve. So these slides are all kind of set up the same way, where there's like the smile, the preoperative smile and the postoperative smile, but most importantly the video clip. So let's see what we can see on this video. Oops. So he can give us a small smile, he can give us a bigger smile, and he can even overdo it and make it like overwork. So he really has very, very good control over this muscle. And I would argue that he's really able to kind of speak to us that expression. Another NF2 patient who had a hypoglossal-facial transfer that gave her good tone, but no movement here, and then we put a little gracilis in, and now she's able to really move that voluntarily. This is another example of some really nice movement. He started off totally flaccid. This one is driven both by a cross-face nerve graft and by the chewing nerve. Another NF2 patient who's now able to really, he started off with nothing and now he's got this nice meaningful movement. I'm not going to say it's gigantic, it's not perfect, but this smile is readable to kids in his class, etc. So this is really, I think, a very worthwhile intervention. This gentleman with NF2 had bilateral facial paralysis, first on the left and then on the right. So on the left, we did a muscle transfer, and then as the right condition worsened, we then did one on the right. And so you can see that he's able to kind of move sort of both sides now. They're not perfectly balanced in the way they're inset, but he's able to get better oral competence and so. So these days, I would say that it's pretty routine to get a result somewhat like this. So here she is with flaccid paralysis on this side, and here she is after the free muscle transfer. This one is actually driven by a cross-face nerve graft, which means that this happens when she's just laughing, and also when you ask her to smile. So some really nice movement there. You can see that coy smile. Is it giant? No, but does it convey meaning? I would say that it really does. Now, the other thing that we talked about on our list is reinnervation, meaning taking advantage of the native facial muscles and driving them by an alternative nerve. What are the choices for those nerves? Well, the hypoglossal nerve that a lot of you have heard about, that's depicted in this piece of art. So the hypoglossal nerve is green. You can cut all or part of it, and you can have it kiss or sew it to the facial nerve stump and have axons go in. You can also use the contralateral facial nerve, which we depict here, or you can use the nerve, these tiny little yellow nerves here that are that go to the temporalis muscle. Or finally, the most popular one is the masseteric nerve, or the one that goes to the masseter muscle, which might be being blocked by my image here. So the problem with the hypoglossal-facial transfer is it was the first nerve that was really commonly used as a donor, and it's very powerful. It's technically pretty straightforward to do, but it does make people's hemitongue somewhat weak, at least using the traditional methods. Here's a lady who had the procedure, and when she's at rest, she looks pretty good. But when she goes to move, you can see there's a lot of mass movement, and she wouldn't call this really a meaningful smile. This individual had this operation on the left side of his face, and you can see that actually what he activates most is a lot of the down pull, just like she does. And so even though these people look great at rest, when they go to try to have movements, they have very poor control, zonal control over those areas. And so we tend to use the 12-7 just simply to provide tone, and then we do something else to really provide smile. So this lady is an example of somebody that we used the deep temporal nerves to restore her smile. So she had multiply recurrent vestibular schwannoma from NF2 and developed facial flaccidity, and then she underwent this nerve transfer, and you can see that what she has for movement here is really quite nice, because better than the gracilis muscle, she's activating her own muscles, so she gets this beautiful crease all the way across. That's the advantage of a direct nerve-to-nerve transfer. This is another example of that 5 to 7 nerve transfer. No smile. Now she's biting, and you can really see dynamically that beautiful movement that she gets when she bites down. So I like what I see here, and even a few of those biting fibers are going into her oculi, and that's kind of normal because sometimes we close our eyes a little bit when we smile. So this is really pretty. This is an example of a 5 to 7 nerve transfer in a younger kid. Smile. We unfortunately caught her right in the middle of a blink with her smile here, but after surgery, about 4 months later, she develops this kind of movement with this nice smile here, and you can see the video here. A lot of really good dynamic movement when she really came in with nothing at all. So this is something that is quite socially useful, and people get really good at using. This is another example of a 5 to 7 nerve transfer, how it really restores that kind of smiling expression. You can, Here you can see it again, going from this position to this position. And then from here into this area. In this particular case, we did the 5 to 7 transfer with the chewing nerve, but we also put a couple of cross-face nerve grafts, one to the eye and one to smile, to try to get both power and reliability and some spontaneity. That way you're not depending completely on the opposite side nor completely on the chewing activity. So this is an example of the 5 to 7 nerve transfer, along with a couple of cross-face nerve grafts. And you can see that he's got this really nice, he's got even a spontaneous eye blink from the cross-face nerve grafts and really a beautiful spontaneous smile. Another example of the 5 to 7, along with a little bit of hypoglossal fibers that also improve our tone. Here he is smiling. We only have distance photographs, unfortunately, on him because of the pandemic. Okay, so hopefully now you get a sense of the different options for smile reanimation in sort of the flaccid face. When we talk about the synkinetic face, like what's demonstrated here, we want to kind of do a bunch of different things. So this is an example of a lot of hypertonicity. This can happen when the facial nerve is intact, when a vestibular schwannoma is resected, but it's beaten up. And when it recovers, it over-regrows, and it overgrows in a disorganized manner. So when this individual is trying to smile, she's getting complete eye closure, something too tight in the face, her lower lip is too high, she's getting dimpling here, and all kinds of pulling in the neck. What do we do when there's too much input to the native facial muscles? What we do is we say that in non-flaccid facial palsy, less is more. We want to take some function away so that we can reveal the good function. This is called downgrading. So downgrading and denervation are what we do in those types of cases. We can do what we call selective neurectomy, where we actually cut out nerve branches, or we can do direct myomectomy, where we take out some of the muscles that are doing ugly actions, or we can weaken the other side a little bit, downgrade the normal function to get better balance. So let's see that looks like. Here's an example of somebody who had a 5 to 7 nerve transfer, and the smile came back pretty good, but then he started to pull down in the frown muscle. In other words, nerve fibers penetrated the frowning triangle here. What do? We give him a shot of local anesthetic here, and then all of a sudden the smile is balanced. We then go on to resect that muscle. It just is a 10-minute office procedure from the inside of the mouth, and we just snip basically the frown muscle, and we're able to change the smile from this to basically here. Sometimes if we weaken the muscle that lines the inner lining of the cheek, we can make a smile that's a little constricted here on her right face, and we just get it to release a little bit more, and it looks a little bit more favorable. Sometimes we snip branches away from the eye, so you can see that this eye up here is too narrow, same with this one, same with this one, just too narrow when they go to smile. If we open up the face and snip away some of the eye branches, then immediately postoperatively, you can see each patient has their postoperative photo right below their preoperative photo. You can see that those eyes are all staying much more open. So that's an example of neurectomy around the eye to prevent that involuntary eye closure. Here's an example of a lady who closes her eye too much when she smiles, and the corner of her mouth is not moving that well. We open up the side of the face like a facelift, we expose all these facial nerve branches, we cut away some, and what she looks like postoperatively is that her eye is much more beautifully balanced, and I would argue that this mouth really is expressing the right sentiments. So in the hypertonic face, if we take away some of the bad actions, we're basically unveiling what really is a pretty decent smile in there. This lady, again, when she's smiling, things are pulling downward. Great, let's open up the face, snip those negative branches away, and she wakes up, and this is the kind of smile that we're seeing. Much better. We already looked at this lady's example, but here's another thing. Too much going on over here. The lip is being artificially pulled up. If we can take away some of the nerve branches and relax it, all of a sudden the smile itself is telling a better story. And another final example, you can see this works in women and men and people really of all ages, older and younger. Again, if we drop down that hyper elevated lower lip, we see something that's a lot more balanced. I mentioned contralateral weakening. So this is a lady where she has normal lower lip function on this side, but on this side it won't pull down. What do? We give her Botox on the healthy side, and if she likes that, we snip away the muscle on the healthy side, and it results in a much more balanced look. So this algorithm sort of says, look, start with a shot of numbing medicine. If they like the shot of numbing medicine, give them Botox. If they like Botox, repeat it and make sure they like it. And if they do that, then finally you can consider surgery. That way we don't run into something that's irreversible until we're sure that the patient's going to like that effect. Okay. So it's so critical to emphasize that any of the interventions that I've talked about require focused facial nerve physical therapy in order to optimize them. So physical therapy in our center is really customized to the individual patient. You can use it to upgrade, meaning trying to take a weaker face and get it to move a bit more by hypertrophying what's there. You can use it to downgrade in a face that's too tight, get it to relax, use massage techniques, mindfulness, and actually digital maneuvers to get the hypertonic face to relax. We use physical therapy post-surgically. After all of these muscle transfers, you got to learn how to use it. After muscle transfers, nerve transfers, muscle removal, or nerve removal, all of the vectors in the face change, and you've got to recalibrate and then retool with focused facial nerve physical therapists. So I can't overemphasize how important that really is. Simple eyelid stretch techniques, like shown in this photo, can get people a better blink. Oftentimes the eyelid weight does most of the trick, but not all of it. And if we do this maneuver of stretching that upper lid for 60 seconds and holding it that way, you can get a better blink that lasts 8 or 12 hours. The physical therapists sometimes do mirror work where you try to make expressions, you look at what's happening in the mirror, and you're able to take advantage of neuroplasticity in your motor cortex in order to more effectively do facial movements. And I would say that when we look at what physical therapy does for our patients, we can see statistically significant improvements in people's objective and subjective scores following those maneuvers. So I really think it's something that's so important to include as part of a comprehensive regimen. I want to spend the last few minutes just talking about future directions in facial paralysis, sort of where are we going and what is on the horizon and what can this population expect. The first really exciting thing is this program that we've developed called Emotrix Plus. And within Emotrix Plus is something called the auto e-face. So I told you back in the beginning of the talk that the e-face is a way that a clinician can kind of grade all the different landmarks and the movements of the face. But Emotrix can basically do that automatically by reading the specific 8 photographs that it's being fed. So it's an automated photo analysis program that scales the photograph in terms of millimeters and provides all of the relevant landmarks and positions and movements that we're interested in with facial paralysis. So you take a photograph like this, you suck it in, and you ask for the facial measurements, and out pops the brow heights on the right and left, and the difference between the eyebrows. Out pops the distance between the upper and the lower eyelid. Out pops how much the mouth moves, etc., etc. And what we've done over the past few years is to make it a little bit fancier. So we started off with Emotrix, and now Emotrix Plus has some additional really important features. Number one, it's got better landmark accuracy. So those dots that you saw on the face are automatically assigned by the program, but sometimes they're not quite in the right position and you have to move them. Increased landmark accuracy makes it much easier for the clinician who wants to assess it. We've also tried to build a nicer user interface. So when you open up the program, it welcomes you in and it says, hey, do you want to analyze a single photograph? Do you want to compare 2 photos, let's say smile before facial reanimation and smile after? Or do you want to take the whole seven photograph series and get an e-face on that? So it's kind of a user interface like that. And this is an example of the single photo. It assigns the dots automatically. It can even read the nasolabial folds now, which it couldn't do before. And when you want a graphic rendering of the static position of the face, it can give you that in a graph. So what this says is that the brow height is totally balanced between the 2 sides, but on the affected side, the eye is too narrow compared with the other side, and the oral commissure only moves about 80% of the other side. When you want to compare two photos, there's a simple drag and drop for those two photos. You drag them in, or if you want to drag in all 7 photos, they're here. And this is an example of what the computer produces for an e-face by simply reading all of those photos automatically. So it gives you resting parameters, the dynamic parameters, and the synkinesis score. So in terms of like patient analysis, things like that Smile Check app, things like the layperson proxy, things like Emotrix Plus, those are going to be the tools of the future that are going to allow us to get data from our patients, even if they travel long distances and need to kind of electronically be assessed later. The other thing that I think is really going to emerge is more neuroprosthetics for facial reanimation, meaning technology that can read one side of the face and then drive the contralateral side, sort of like what I've depicted in this picture. Just before I end, I want to make the point that not only will neuroprosthetic implantable devices help us, but I think there's going to be a huge market for what we call wearable devices. So a pair of eyeglasses that reads the blink on one side and stimulates a blink on the other side. You could even read smile on one side and trigger that on the other side. So lots of those things I think you're going to see coming down the pipeline. And I frankly am excited about the possibility of minimizing the need for surgery to restore some of these movements. So I want to end with the idea that the smile really looks different on every face, and the goal of the facial reanimation surgeon is to really personalize the smile. I like this photo because it randomly captures, like, this is me with my mom and my daughter, and I think we just absolutely, without planning it, kind of captured 3 of the real mainstay types of smiles. This more full denture smile where I have the upper and lower dentition showing. My mom has more of a zygomatic major smile with the 2 corners going up, and Mackenzie has sort of a closed mouth smile. So smiles are different, and but they're worth it, and they express joy on the face, and I think that facial reanimation is just it's a worthwhile pursuit, especially in the NF2 community, where the idea of enhancing quality of life with our interventions is so important. So thank you so much for your attention, and I'm really happy to answer any questions at this point.
Perfect. That concludes the session. Again, if you have any questions for Dr. Hadlock, please either submit those through Hoover or talk to Kate about that, and we'll do our best to get the answers for you. Thank you so much for sticking with us this afternoon through all the challenges. We really appreciate that. Thank you for contributing to a great session. We'll see you later in one of the other sessions. Thank you.